we're dealing with babies, there's some key factors we want to keep in mind when we're looking at babies. We'll start from the head and work our way down. When you start off in the head, babies' heads are bigger in proportion to their size than adults. So 25% of their body weight's in their head, right? So when a baby falls, what's the first thing it lands on? On its head, right? Head trauma is the number one cause of traumatic death in babies is head trauma, right? So their heads, they got no control over it. They got those heads that flop back, front, side to side, because they've got no muscular control in the neck, right? Maybe we say a baby is from what age group? From birth to 1 year old or 12 months, right? So they got really floppy heads and necks. So when you see parents taking babies, go whee, and they're throwing up and catching them, whee, throwing up and catching them, that torque. It's not good for a baby to have its head torquing like that, right? To give you an idea of what it's like taking, so they're 12 pound, or they're big, 25% of their body weight's in their head. You take me, I'm 220 pounds. Take 25% of my body weight. So that's like a 50-pound barbell plate, or 55-pound barbell plate. Take that, strap it to my head, paralyze the muscles in my neck, and shake me. How much control do you think I'm going to have over my neck? I'm just going to snap like a twig. So shaken baby syndrome, when they're shaking the baby, you got all that weight up inside the head, snapping back and forth. Huge damage to the neck and spine, right? So they got these big, huge floppy chests, or heads, right? The next thing is they've got these little things called soft spots, or fontanelles, okay? All those things are just like little openings where the skull cap hasn't fully come together and fused together yet, so they've got these little holes that are still in the skull. Because when the baby's being born, those skull pieces will kind of ride over themselves to allow for the baby's birth down the birth canal, so they'll come out looking like a big cone head, right? You wonder what happened to your baby. Like when your baby comes, Jamie, and it comes out with this big cone head, don't worry, it's not going to stay like that, right? Eventually the head, the skull pieces kind of come back to normal,
that to my first
and then they fuse. So, exactly. All right. So babies breathe through their nose, not their mouth. The only time a baby breathes through its mouth is when it's about to cry. They have that moment of silence, and then rah, they scream and cry, right? Otherwise, a baby breathes through its nose. You can really hear when they start to get those respiratory infections and colds. You can really hear it wheezing away through their nose. Babies have huge tongues. They're bigger in proportion to their size than adults, and they produce copious amounts of secretions. They drool, free pour drool on. And when you put something in a baby's hand, what's the first thing it does with it? Oh, everything goes towards the mouth, right? They're very orally fixated. All they care about are bees, or peeing, pooping, and boobs and eating, right? As you get older, that's pretty much right. It doesn't really change a hell of a lot, but yeah, everything goes to their mouth. Very orally fixated, right? They have to taste everything. So what happened is this baby, their heads are bigger, those little fontanelles or soft spots, if they're sunken in, they're usually an indication of some dehydration. A baby's blood volume, how much blood volume do you think is in a baby, a newborn baby? Hold up that little water bottle there. How much is in it? How much does it say?
Half a liter.
Half a liter, so 500 milliliters. That's the entire equivalent blood volume of a 15-pound baby. 15 pounds. So every 30 pounds, add or subtract a liter. So a newborn baby that weighs 5.5 pounds, 6 pounds, it's a third of that. A third of that bottle. Like, huge swig, that's it, it's done. They haven't got blood volume to spare. Okay, so if a baby gets cut, they have nothing to spare. It's like a bird, you clip the nails too far back, the bird can get to some severe shock because it's losing volume. They haven't got a lot, right? So babies, they cannot be bleeding, so you've got to get on them real quick, right? So sunken fontanelle, dehydration, babies peeing, not drinking enough fluids, got diarrhea, 5 or 6 diapers, they can start to go into some volume problems, go into shock because of their volume is so low. So they need to keep their volume up really, really high. All right? The trachea, or the windpipe on a baby. If I do this with me, you can hear a slight change in the tone of my voice, right? When I crank my head back. You do that with a baby, and you'll kink its windpipe in half like a garden hose. Those little rings of cartilage you feel in your neck, the hyaline cartilage here, provide flexibility and strength to the windpipe. So when I go, really hard and fast, when I'm running, I'm running away from the saber-toothed tiger, so to speak, my windpipe doesn't collapse. Those rings of cartilage provide strength and keeps the windpipe open, kind of like the rings in a vacuum cleaner hose, right? But in a baby, they're very soft and pliable. So when I crank the head back like this, you can hyperextend the baby's neck and kink that windpipe in half like a garden hose. So when I tilt the baby's head back, it must be to the neutral or sniff position, slightly elevated like this. Okay? Cranking the head way back is obviously going to cause a kink in this windpipe, and you're going to have difficulty trying to get air in there, or you'll think the baby's got an airway obstruction. Neutral or sniff position with the baby's head is all we need. Okay? Now the baby's lungs are about the size of walnuts. Okay, it's like putting 2 walnuts in your cheeks. So how much volume do I give a baby when I actually ventilate it?
Hardly anything.
Do I want to go? If you're taking a lung full of air and you're ventilating a baby, it's too much. I'm literally giving a baby 21% oxygen. If you're into BVMs and understanding how BVM works, I can hold my breath and go. I can grab atmospheric air and ventilate a baby. They actually get more oxygen than I would give you if I was ventilating you, right? Because I'm just grabbing atmospheric air and ventilating into the baby's lungs. What's the key to remember when we're ventilating anybody? What's the key things we look for? Chest rise, right? So we don't want to be over-ventilating. The little alveoli, those little tiny air sacs inside their lungs, they're popping off 1 air sac per second to the age of 8 when their lungs are fully developed. So you've got a baby who's a newborn baby. When your baby's born, let's say we got about 300 million air sacs in our lungs. If I took your lungs right now and I unfolded them on the floor here, how big a surface area do you think your lungs actually take up to absorb oxygen? Anybody got an idea how big it would be? Do you think it would fill this room up, or half this room, or what? It would fill this room and that room on the other side. It's the entire volume of a tennis court, a doubles tennis court. That's the surface area that's compressed into 300 million air sacs, squished into your little chest. That's how much surface area is picking up oxygen. It's an incredible amount. When you're going, you need a huge amount of surface area to pick that up. So it's all compressed and put down in these big packs inside your chest called lungs. So my 300 million air sacs are going to overventilate 24 million pretty easily, right? So they're growing off a new air sac per second. So their lungs are still growing. So volume is important. When you ventilate a baby, we ventilate the mouth and nose. They're very close together, so we seal the mouth and nose with our mouth, and we ventilate just enough to see the chest rise and fall. That's it. So when I get my mouth over the top, little chin lift. See that? See the chest moves up a little bit? That's all. I'm not going, I'm blowing the diaper off the legs here, right? Just enough to see the chest rise and fall is the key. Does that make sense? So when a baby breathes, its diaphragm does the majority of the work. Okay, they got those big Molson muscles. The belly is the diaphragm is the principal muscle for breathing for a baby. The intercostal muscles aren't fully developed yet, so the baby breathes from the diaphragm. So when you blow air into a baby's chest, what goes up and down? Its chest or its belly?
What goes chest?
When I blow air into this baby, what's going to go up and down? If we know it breathes from the belly, and I blow air into this kid, what's going to go up and down, the chest or the belly? You say the belly, but where are the lungs?
Chest.
They're in the chest, right? When I'm positive pressure blowing air in, the little balloons inside the lungs go up and down. But when I go, or when I pull my diaphragm down, that creates a vacuum. That sucks air into the chest. So when a baby breathes, you'll see its belly moving up and down. But when you ventilate, the chest should go up and down. Does that make sense? So if you see the belly going up, you're blowing air into the stomach. We don't want that. When you overinflate baby's stomach, they got lots of formula, lots of breast milk, lots of liquids, and that hydrochloric acid in the stomach. They vomit that up. Where does it go? Into the lungs. Not a good place for it to go. Those alveoli are still growing. You got all that hydrochloric acid in there. It's going to eat away at stuff. So we cannot let that fluid and that acidity get into the lungs. Does that make sense? Okay, good. So when you blow air in, the chest should go up and down, not the stomach. When they breathe, the stomach sucks air into the lungs. It's a different type of process, right? Now, When we're checking for a pulse on a baby, where do I check for a pulse on a baby? Excuse me, got a question position. Hello, right? We check the bicep, between the bicep and the tricep, like Gerald said, you squeeze the muscle in the bicep, and we're going to check, we're not going to need to do this because there's girls there. Like that, eh? So you check right between the bicep and the tricep, right there. Try it. Find it on yourself. Always go skin to skin. Right?
Sometimes you feel a pulse in the back, so you use the fingers.
Got that? So here's the cool thing about this, because later on you're going to see this. This is kind of interesting. If I go like this, right? Watch the skin in my hands. Now let go. See the color comes back right away? Right? Here and here. Here and here. You don't have to make the sound. Same thing with the armpit. Every place you guys feel a pulse is an indirect pressure point. Properly applied, an indirect pressure point works really effectively. Just by simply putting pressure in the right spot, you see the color come back right away. So it works really, really effectively, because when we talk about bleeding later, anytime you feel a pulse point, here and here, here, carotid arteries, temporal arteries, inside of your jaw right here, we talk about nosebleeds later, inside the groin, back of the knee, top of the foot, any place you feel a pulse, any point beyond that pulse point, you squeeze that pulse point, you control bleeding down there. Okay, it's one of the principal areas that we go with indirect pressure point. Just as a little, it'll come back and you'll remember it later. All right, so babies, we check a pulse in the arm, not in the neck, because they're like little football players, you have no necks anyway. And like Gerald said, lots of cutaneous fat tissue in there, and you're pushing around in there, you don't really get a good feel for a trachea and a landmark for the carotid anyway. Babies can't stand it when you flick their feet. So when we're assessing responsiveness on a baby, we don't knuckle the sternum, okay? You just simply flick the feet. Baby, baby, wake up, wake up. Flick, 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 flick. Right? Or baby, baby, baby. Flick, flick, shake, shake. And the baby should respond. If the baby doesn't respond, then we have an unresponsive baby. Continue on from there. Make sense? So that's head to toe anatomical differences for little babies.